Good morning. This presentation is going to describe the descriptive epidemiology according to person, place, and time. And you can find this in your text, Introduction to Epidemiology, Chapter 5. Our objectives are here. I'm not going to go over them. And what does descriptive epidemiology allow us to do? It describes the extent of a public health problem, communicate a public health problem with the use of tables and graphs, which makes things much more clear, identify who's at greatest risk for selected health-related states or events, and use surveillance methods to monitor whether unusual health-related states or events exist, and evaluate public health intervention programs. Understand how descriptive epidemiology can provide clues as to the cause of disease. A person's characteristics. You'll see this in the text, so I'm not going to go over that. And you can see, well, as you said, descriptive data answers the who question. So we're looking at specific things, who. And these include what descriptors are available. Characteristics of the person include these as well. Age, sex, marital status, all of these things here. Age shows greater variation than rates defined by almost any other personal attribute. So you'll find that you'll see when you look at the age graphs that specific ages have increase in illness. For example, perhaps, I don't know if this is true or not, people in their late 20s, early 30s have an increase in sexually transmitted infections. I don't know if that's true. I'm just pulling that out of my hat, but that I'm just using it as an example. Latency effects. Age effects on mortality may reflect the long latency period between environmental exposures and the subsequent development of disease. For example, let's talk about exposure to carcinogens. So someone may have been exposed to carcinogens as they worked, and it had no ill effects until they retired, and then they developed mesothelioma. So that's an example of that. Multimodality of trends. There are several peaks and declines in the frequency of disease at different ages, and we spoke to that in our last slide. Look at this one. Death rates for motor vehicle related injuries in the United States according to age. And this, again, you know, these statistics are old, but I think that if you looked at them, they would be similar. But you can look at where it peaks. That's almost surprising to me. It peaks at rates per 100,000. Oh no, here I go. I was looking at it wrong. Age 20 to 24, highest, right? And then when you get over here, the aged population, 75 to 85, it spikes up there again. Interesting. The biologic clock phenomenon. This refers to an endogenous process associated with increased vulnerability to disease. So our as we age, our immune system doesn't work as well. And aging can trigger the appearance or conditions believed to have genetic basis, like Alzheimer's disease, breast cancer, things like that as we age. So someone at age 18 with the BRCA gene has a very low incidence of breast cancer, but a patient in their mid to late 30s with the BRCA gene will have a much higher rate of breast cancer. Life cycle and behavioral phenomena. Young people exhibit personal traits, so like we know risk-taking, because they have that. If you think back of when you took psychology, they have that thought process that they are invincible. Elderly population experiences may include retirement syndrome, and that's a bereavement process. It's really, I mean, I have seen it in people who have retired, that they just, it's like their purpose in life is gone. It's very sad. Lung cancer death rates per capita, cigarette consumption. Look at that. Look at that spike there in the years. And, smoking used to be so incredibly prevalent. And per capita, look at female, less women smoked, more men smoked. And it looks like it peaked here in like, what, 1995 around, and it's steadily dropping. And a lot of that has to do with, oh gosh, this slide's terrible, but a lot of it has to do with the fact that people just don't smoke anymore. The great majority, at least I see in practice. So here we go, the leading causes of death. Now this statistic is from 2005. Maybe you can find something more recent. I would love that, because we should have something more recent now. This is 10 years old, so usually new data comes out every 10 years, and I'm so fascinated to see if there's been any changes. So, but heart disease continues to be the #1 cause of death. Cancer 2, cerebral vascular disease or strokes third, and so on and so forth. Now let's look at this one, sex differences, the female paradox. Reports from the 70s indicated female age standardized morbidity rates for many acute and chronic conditions were higher than rates for male. Even the mortality was higher among males. And the higher female rates were for pain, asthma, and some lung difficulties. And, this is really something we need to, I think it's changing, hopefully. I want to say back in I was working in the hospital still, so it was like 2007, something like that. I had a friend that I worked with, female. She was in her mid to late 40s, developed chest pain, went to the emergency room. They diagnosed her with an upper respiratory infection, sent her home. The chest pains persist. She came back to the emergency room, same thing. You're going to be fine, go home. She went to a different hospital. She was having a heart attack. Ended up needing coronary bypass surgery. So, women, I think oftentimes, at least they did back then. Now the protocols are different in the emergency room for chest pain. But certain health conditions were compartmentalized as male, and that women were off, weren't considered. But that's changing, has to change. Okay. And look at this, the number of males and females in the United States across the age span, males and females. Ethnicity matters. So which race is most likely to have diabetes proportional to the population? American Indians, non-Hispanic blacks, Hispanic Latino Americans, and non-Hispanic whites. So those are who are at greatest risk of diabetes, and that's ethnicity. And I think about it, when I think of ethnicity, that's genetics. Here's a short-term trend example for prostate cancer. You can see those rates are going down. I think maybe because when I see these rates that go down, I think a lot of it has to do with early detection and treatment, nativity and migration. This refers to the place of origin of the individual. Categories are foreign-born and native-born. And there's a Hispanic mortality paradox. Hispanics have overall lower mortality rate compared to non-Hispanic whites, despite their less advantaged socioeconomic profile. And why is this happening? It's interesting. Is it because of underreporting, or is it Salmon bias effect, which means that they return to their native country before they die? That can happen. I know, because I tell you what, I have been in healthcare for a long time. I have met so many different people, and ethnicity and culture has always fascinated me. I love to know why people do certain things. And so I ask questions, and people love to talk about their culture. They're proud of it, and they want to talk about it. And many people who come here as immigrants, they come here and they work and they live, but when they get to be a certain age, the age of retirement, they want to go back with home. And home to them is sometimes United States, but sometimes it's their native country. Maybe it's Albania or maybe it's Mexico. It could be. But sometimes that happens. Place characteristics. It's descriptive data by place addresses the where question. So these data often involve comparisons between or among geographic regions, in groups before and after migration, and between twins raised in different settings. Types of place comparisons, international geographic variations, and urban-rural differences. And there are true differences between these place comparisons. And localized occurrence of disease. I can give you an example of localized occurrence of disease right now. I worked in, where was I? I don't even remember. Norwich, I think, by the airport. I saw 3 cases of COVID in one day. Tells me that there's a spike coming, right? Then I worked the next 2 days in a different location. 0. So, what does that lead me to believe? That perhaps there is a spike in Norwich in these, were these people travelers? Did they just get off a plane? Because there are a lot of patients who get off planes and come right to the clinic. So there are a lot of questions that left me with. And it also dispelled my initial thought that, oh, COVID's coming back. Well, yeah, maybe COVID's coming back in Norwich, but not other places. So many things to consider. All right. More statistics. Fatal occupational injury rates by state. Let's see who has the most. Oh, look at that. That's interesting. Alaska and up in here, in this area here, down in Alabama. I wonder why. I know that so much farming goes on in this area. I don't know what you call it, the Central Plains maybe, but maybe that has something to do with it. I'm not sure. But again, makes me want to, these types of statistics make me want to dig deeper and find out why? Why is that? Why is it higher there? All right, so reasons for place variation in disease, gene environment interaction, influence of the climate, lead poisoning in the inner cities. Oops, I went too far. Oh well, that's okay. Um, so, oh no, I didn't. So in the United States, comparisons can be made by region, state, even county. So there are higher rates of leukemia in the Midwest, state-by-state variations in infectious vector-borne parasitic diseases. So we know there are certain areas where there are spikes in Lyme disease. And I see, because I look to see whether or not I should be treating for tick bites. Because there is some, it used to be, yes, if there's a tick bite, go ahead, treat them with a dose of doxy. But now there is some conflicting data out there as to whether or not you should do that. Only if you live in a region with a high prevalence. So you have to know that. Here's a study, the rich live longer everywhere. Time characteristics. This is the when question. So epidemiologic investigations range from hours to weeks, years, and decades. Short-term disease incubation periods of a few hours can be as important to the epidemiologist as long-term latency periods for chronic disease. And another term you're going to see used occasionally for time factors is temporal, which means time, or refers to time-related elements or issues. Types of trends, you have cyclic trends, secular trends, short-term trends. And here's an example of trends. What is this? Cycles of, I can't see because, okay. Now, communicating health data and identifying who's at greatest risk. So we talked about the who, where, and when already, and there are some examples in your textbook, and you can find probably more recent data because, as I said, we're at the cusp now. Most data that we're looking at now was generated in 2005. So this is 2025. We should have new data by now because that's 20 years. Um, all right, new topic. We're going to talk about the transition from data to information to message. And data is the numerical information from selected variables, observations, or measurements. Information is the data with enough context provided to allow people to analyze and determine meanings, and message is the information with the addition of interpretation. Answers questions such as, what does this mean to me and why should I care? What am I supposed to do about it? So think about it. So we recently had a boil water. Okay, so I want to know, okay, what does that mean to me? Does it affect me? Do I have to boil my water? And why? Why do I have to boil my water? What do I care? Why do I care about it? And what am I supposed to do about it? Well, I'm supposed to boil my water. So these are all public health initiatives or messages that need to get out to the public. And there are varying ways that they do it. They use television a lot and radio a lot, but I'm seeing more and more capacity for texting, which I like. Some people don't like it because they think it's an invasion of their privacy. I don't care. If there's something that's important that I should know about, send me a text. All right, so here's some examples of descriptive epidata information message applied, and this is pretty much what I was talking about. And we're seeing this now with the resurgence of measles in some areas. So, it's important. I didn't realize this until I think I was getting my first degree, I think, my nursing degree. And I had my titers done, and my measles vaccine was no longer effective. So I had to get a booster. And then when I was getting my doctoral degree, it wasn't good anymore again. So I had to get another one. So I probably should get tested again just to check. But when you think about it, um, yeah, getting measles immunizations is not a bad thing. Um, and most people don't realize that they're supposed to get tetanus shots every 10 years, and the important part of that is the pertussis piece of it. It's diphtheria, tetanus, and pertussis. So very important considerations. Population pyramids. A stationary pyramid is a population that consists of countries with low fertility and low mortality. It's similar to a constrictive pyramid. An expansive pyramid is a population pyramid that's very wide at the base, indicating high birth and death rates. A constrictive pyramid is it comes in at the bottom. So it's like this last one here. The population is generally older on average, as the country has long life expectancy and low death rate, but also a low birth rate. This pyramid is becoming more common, especially when immigrants are factored out, and there's a typical pattern for a very developed country with a high level of education, easy access to and incentive to use birth control, good health care, and few negative environmental factors. So we're seeing that in the United States now. Our birth rate is pretty low right now. And if you looked at the statistic and you said, oh, well, gosh, there's lots of babies being born every year, you need to look at the big picture. How many people, and because we have, number one, we have an aging population. So our death rate is going to be going up exponentially because we have an aging population, right? All these baby boomers are in their now 70s and 80s. And here's an example of a population pyramid in the United States. I find that hard to believe that we have 0 people in the United States that are 100 years or older. I don't believe that. But this is from 2020. Dependency ratio. How to calculate this, and this is important. You're going to need to know this. Population less than 15 and greater than 65 is divided by the population 15 to 64 years of age. Multiply that by 100 to express as a percentage. The interpretation is that there are blank dependents for every 100 people of working age. And trends in dependency rates, you can see that here. Public health surveillance, implicit in descriptive epidemiology, the notion of public health surveillance. This is the collection, analysis, interpretation, and dissemination of health data. This is defined as the ongoing systemic collection analysis, and we talked about this. It establishes a baseline in rated disease. So, I do this in clinic when I report things to the Illinois Department of Public Health. Surveillance data, it helps to identify sudden changes, long-term trends, risk factors, control measures. It helps with planning and estimate of the magnitude of the problem. But sometimes they're not right. Remember, they said with COVID, all we needed to do was mask up for 2 weeks and the problem would be solved, and it was more like 2 years. Or it was, some explanations for observed changes in the frequency and pattern of cases in a surveillance system which are not due to changes in the risk. Inconsistent interpretation and application of case definition, changes in the definition, people like to change that definition, change in surveillance and reporting, improved diagnoses, so we're finding things earlier and sooner, change in diagnostic criteria, reporting requirements, population, and change in the level and emphasis of active case detection, and then random events, increased public awareness. Surveillance for evaluation. Health programs may be aimed at the following, and here's some examples. Vaccine rates, smoking, healthy diet, obesity screening, all of those things. Vaccine preventable diseases. We've seen so many cases of measles out there right now. You have a healthy individual. It's just inconvenience, but you get someone who's immunocompromised, it can be a death sentence. We have active and passive types of surveillance. Passive surveillance, laboratories, physicians, or others who regularly report cases of disease and death to the local or state health department, like I do. Active surveillance is local or health departments assume that they are specifically trained for this, and they gather specific information from laboratories, physicians, healthcare providers, and the general population. Syndromic surveillance. This is the ongoing systemic collection of and analysis of data. It gives us automated real-time indicators for disease. Seeing more and more of this, like GI influenza rates. We see that, it says, oh, where's there today? Where are we seeing influenza? And I've seen one case of influenza. What determines the value of a surveillance program? It determines whether appropriate actions have been taken to date. whether the information was used to make decisions, and whether prevalence of the outcome variable relates to the level of distribution, whether the information may be used in the future. So there are a lot of things to consider in descriptive studies. There can always be variables that can skew the data. Analytic epidemiologic studies are better for minimizing the threat of confounding. Nevertheless, descriptive studies are a good first step in the search for cause of health-related events.